Welcome everyone to today's webinar, Operationalizing Population Health. I am Brian Zimmerman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to introduce our presenter. Dr. Michael Blackman joined Allscripts from McKesson and now provides medical leadership across the Allscripts Care in Motion suite. Passionate about looking for methods to improve care, he has worked with multiple hospitals and health systems to improve how EHRs are used to both advance patient outcomes and improve clinician workflow. Additionally, he was a leader in the early work to enable the widespread use of the electronic prescribing of controlled substances. A former assistant professor of medicine at the University of Massachusetts School of Medicine, Dr. Blackman holds an MD from Brown University and an MBA from the University of Michigan. He completed his residency in internal medicine and pediatrics at the University of Miami-Jackson Memorial Hospital. At this time, I'm pleased to turn the floor over to Dr. Blackman to begin today's presentation.
Great. Thank you, Brian, and thanks to everyone for joining us today. As Brian mentioned, we will certainly have time for questions, so please submit them through the link at the bottom. So I wanted to start today by sort of talking about our objectives for a quick minute. So hopefully at the end of the hour today, you'll see that there are multiple approaches to population health. Think about how the population health software solutions can help support that strategy, and most importantly, think about what one needs to do to operationalize a population health strategy. But let's first start with what is population health. So population health often goes by multiple terms. The one most commonly used you'll hear is population health, but historically that really refers to really public health as we think about broad health outcomes, determinants, policies, and the interventions attached with them. What we're going to be talking about today sometimes goes by the term population health management or population health medicine, where we look at the process of how we address population health needs at the population level and, frankly, the healthcare level. And there are multiple different strategies depending on your goal and depending on how you decide to define your population. And those can be as varied as simply, by geography, by disease, if you're looking at it strictly from a payment point of view, perhaps by payer. All of those are completely valid ways to approach it. But why is that even important? Are you hearing, questions like these? There's lots of discussion on this topic. The other day I performed a quick Google search using a couple of different population health related descriptions, all of which consistently returned about 300 million items. So lots of discussion in this area, clearly a lot of attention. But we need, at its root, it's about doing more with less and a desire to improve the quality of care, especially as we're living in this world of ever-changing payment models. So as we think about this, what's driving some of these questions? So as will come to no surprise to anybody listening to this webinar, healthcare expenditures keep increasing. And equally, again, not as a surprise, commonly discussed that the U.S. spends more per capita than any other developed country on healthcare. On this slide, I picked a sampling just for reference. The second highest, I should say, spending per capita happens to be Switzerland. But at the end of the day, we're spending today roughly about 18%, so just under a fifth, of the U.S. GDP on healthcare. Now, it's certainly hubris to make absolute predictions, especially about healthcare, but there's no question that we spend a lot of money, and the rate of growth, frankly, isn't sustainable. As we look at the rate of growth for the countries here, over the past 5 years or so, we're still seeing tremendous increases in cost. And that's not going to work. Now, if we had outcomes that matched the expenditures, so if our outcomes were much better than everybody else's, you could make an argument that the money is extremely well spent, we should keep doing it, we're getting those results. But what won't come as a surprise is that we're not. So if we're using life expectancy as a surrogate measure for outcomes, our outcomes here are lesser than every other country on this list. Even the lowest spending country here, which is Israel, spending a little less than a third of what we do, has better outcomes. Now, I fully recognize that life expectancy is multifactorial, so healthcare is only one of the drivers there, and we'll get into that in a couple of minutes. But as we look at where healthcare payment is today, we're continuing to move away from the traditional, fee-for-service, pay-as-you-go method to more value-based systems, often referred to as alternative payment models. And what those will end up looking like, frankly, is anybody's good guess. A lot of good things going on, a lot of experimentation, in an effort to drive to, paying for performance, basically. But we're down to approximately 40% of healthcare dollars still in those legacy payment methods, and you can see how we're moving towards bundling in the other areas. But as we move forward, where are we likely going? So this is information from the Healthcare Learning and Action Network, which is a public-private partnership originally started by the Department of Health and Human Services, and these are their targets for where they want to see us go. Less than 10 years from now, the goal is to have all of Medicare under alternative payment models, and even half of the commercial payers and about half of Medicaid as well. So we're going to continue to see this change in how we do business. And as we move to these alternative payment models, we're going to need to continue to think more holistically about how we approach care and how it's delivered. And this is indeed a change of thinking from those traditional cost buckets, inpatient, outpatient, lab, pharmacy, etc. And think about what's the impact on the overall cost versus whose bucket does it fall in. So the World Health Organization defines a smart healthcare community as one that is safe, timely, effective, efficient, patient-centered, and provides care to everyone. And so as we're thinking about population health and population health medicine, no matter how one has defined that population, these are the things we have to ensure, that we make sure that we get the appropriate care to patients in a timely, efficient, and effective manner. And doing this creates value not only for patients, but for the entire system. I mentioned before for a minute that we talked about life expectancy as a surrogate outcome. And I think it's a reasonable surrogate outcome for quality, but it's not only affected by healthcare. So as you can see here, that clinical care, and studies vary a little bit on this, but they're all fairly similar, that clinical care accounts for about 20%, give or take, of your overall health determinants. Another 30% on health behaviors, so things that are clearly affected by medical care. As a primary care physician, certainly spend a lot of time talking to patients about tobacco use, their diet, exercise, alcohol and drugs, and other factors that affect their health outcomes. But that still only gets us to about half. Physical environment and other social factors, which are increasingly getting more attention, comprise the other 50%. So all of those factors together, drive someone's health outcomes, both their quality of life, their length of life. So at the end of the day, as we look at these, how do we need to consider what we can affect, how we can affect them, and how we can put the right information in front of people to support the entire population. There is sometimes a tendency to push everything to the end-using, or patient-facing clinician, whether that's the nurse practitioner, a PA, the physician, whomever it may be who's actively seeing the patient. But the fact of the matter remains that those people are incredibly busy with incredibly packed schedules, and so we can't keep pushing everything to them. We have to look at how we can empower the entire team, and that's part of that population health strategy. Certainly as a former full-time practicing primary care doc, and certainly primary care physicians today, if you're lucky, you have a patient scheduled every 15 minutes. If you're not lucky, you have one scheduled every 10. And so when you're seeing patients that perhaps have a lower acuity condition, say someone in their 20s with an upper respiratory infection, the first reaction is frankly one of a little bit of relief of this will be relatively quick, I can get through, I can catch up a little bit, because I just spent 45 minutes with an elderly patient with congestive heart failure, diabetes, and hypertension who was scheduled in that same kind of 15-minute slot. And so how do we empower the team to take care of the whole population and move care to where it best deserves to be? So as we think about the goals of population health management across the board, first off, obviously to improve clinical care. We need to continue to do more with less and compete in that changing payment environment I mentioned. It's about supporting that smart healthcare community. It's about creating value. So one of the ways we can do this, and frankly, to help with this, is using, what is that population health solution? And a population health solution at its basis has four pillars. The first is data aggregation. How do we get the data, all the data we need? Most people seek care in multiple environments. Their data is spread across multiple systems, which, yes, there's been great work in terms of interoperability. We're not as far along as we'd like to be in general, but there are ways to do this. So to combine that data from across sources, normalize it so you can present it to people in a way that makes it good information. Second, the analytics component. How do you then leverage that data to create information, understand what's going on with your patient population broadly, and when appropriate, obviously, for the patient in front of you? I neglected to mention earlier that as we think about population health, it has two broad components. One is, how do I take care of the patient who's in front of me? How do I address the population writ large? They're the same data, just sliced different ways for different people asking slightly different questions. Next, care coordination. Using the analytics, how to identify who needs extra time, who's not coming in, how do I get them in? And it's about managing those potentially high risk or high cost patients. But I should note that as one's looking at this, it's not always your highest cost patients that you want to manage. Frankly, your highest cost patients may be high cost simply because they have a high cost illness and they're on very expensive medications. They could be extremely well managed and there may be nothing one can do to lower that patient's cost. However, there may be patients who are not quite as expensive, who are seeking care in the wrong environment, too many ED visits, where you can affect those decisions. So it's a function of both looking at the cost, looking at what the issues are, and then determining what's that population that would benefit from additional coordination and additional help. And finally, patient engagement. How do we continue to involve patients in their care, make them more interested? Healthcare is always better when done with you rather than to you. So how can we make patients take an interest there? And certainly plenty do, but we're seeing changes there as well. So across this, we want to realize value. So the four, broadly, four steps as we look at realizing value. First, as we're implementing a population health solution, what are the desired goals? What are the outcomes you're looking for? What are you trying to get to? Sometimes this step gets skipped a little bit, and you'll see people later in the process going, oh, this is what we're trying to look for, but we didn't set it up right. So as part of that, you need to identify what data and processes are needed to support the goals. This is very important work to do earlier in the process rather than later. Sometimes, especially if you're implementing software solutions, these items are discovered at implementation, at which point you have to back up and do a lot of rework. Where is that data coming from? Are you capturing it in a way that makes sense? Is it being captured consistently? most, or many, I should say, many EHRs provide you multiple ways to do things, and ensuring that the team is aware of, how you expect the system to be used, how to move it forward effectively, and how that data is going to be used makes a big difference. Because if someone doesn't understand the reason for a specific data element capture, often they'll take less interest and put it in whichever way makes sense to them, which may not work for the team as a whole. Finally, it's important to remember that this work is never done. We need continuous improvement to support those organizational goals as they continue to evolve. And taking that broad view, as I mentioned before, looking at the entire continuum of care, what can you do as an outpatient versus an inpatient, what requires a phone call, what requires an in-person visit, etc. All of those are really important steps. But going back to the beginning, the first step is defining that strategy. What is driving? Are you simply looking for clinical improvements, meeting financial or contract goals with alternative payment models, user satisfaction, and the users in this case are members of the healthcare team, or is this about improving patient satisfaction? The fact of the matter is that it's never about one of these, it's about all of them, or some combination thereof. So you need to know what you want to measure, what the data source is. And as mentioned earlier, bringing that information from multiple places together to save money and time. There's often no need to repeat a test if that result is available from elsewhere. Sometimes tests get repeated simply because people didn't have access to the data. And so as we look at those desired outcomes, establish the KPIs. How are you going to measure it? How do you know if you're making progress or not, and what are those targets? As we think back to some of the early stages of meaningful use, there were a lot of process targets. Absolutely reasonable. We had to start somewhere, but they didn't always move the needle on care in clinical quality. So as one thinks about your outcome measures or KPIs, however you choose to define them, think about those goals and are they making a difference to you, either clinically, financially, or hopefully both. So supporting all of this becomes the Pop Health software solution. And truthfully, and this may sound like a little bit of heresy coming from someone who works for a software vendor, but it's not just about the technology, but rather what can you do with it? What do you need your tools to do? Because tools, frankly, are just that, tools. They don't solve issues by themselves, but they help identify, they help improve processes, and they help identify where to look. One of the things that we see as we look at populations is variances in care. And I'm not suggesting that all variances are bad. Patients are individuals. You want to treat each patient appropriately. That said, however, we can see differences in the way care is delivered in that process that truly do affect outcomes. To take something relatively simple, the percentage of patients in a given practice receiving flu shots in a given year. Well, if one practice is getting 95% of their patients flu shots and another practice is getting 50% of their patients flu shots, what's the difference? And how do you identify where those practices are so you can look at those differences to understand what they're doing differently, how can you improve the actual workflow process? Because, always a little bit risky to say, always or never in healthcare, but I would certainly be comfortable suggesting that no one, absolutely no one, is out trying to provide substandard care. Everyone wants to do a good job, and those variances, in that 50% practice that it's identified talking about, only getting half of their patients flu shots, it's not that the people don't want to, but there's something wrong with the process. So if you have a large health system with tens of practices, how do you identify where those issues are? And frankly, the same could be said for differences between units in an inpatient setting as well. So those variances are usually the result of difference in processes, which you need to address to both improve efficiency, improve quality, and decrease cost. So what tools do you need? We need tools that are going to effectively support all four of those pillars that I mentioned before about population health: the data aggregation, the analytics, the care coordination, and the patient engagement. But those tools need to fit within the workflows so they can be used effectively, turning that data into information which can be used to assist with direct patient care and identify who might need additional information. So those tools need to support both the patient being seen and those not being seen. And frankly, thinking about patients not being seen is a shift in the way healthcare is provided. Traditionally, we've waited for people to come in, providing episodic care. They scheduled time, they came in, or they didn't. But as we move forward, and especially under alternative payment models, we're looking at a system where you are both rewarded and penalized in some cases, whether the patients come in or not. So how do you identify those? How do you reach out appropriately, to make sure that those patients are coming in? And so that gets us to the patient engagement piece. Facilitating, better ways to communicate with patients, involve them in their care. Going back to, again, to the early days of meaningful use, people were required to have patient portals. Lots of people have them. Most patients do. I personally have 3. It's a lot to keep track of with different passwords, different password rules. And again, what's driving someone to go there? So as we move forward, on those, how do we get to a place where we can bring people, bring the information to them, as opposed to waiting for them to come? So it's pushing the information to them in a way that makes sense. And so as we move forward, sorry, I lost my train of thought for a second. As we move forward, and you'll often hear those patients sometimes described it as consumers. And many things are driving that shift. But the reimbursement structure changes are part of that. As patients assume more direct responsibility for payment through things like high deductible plans, this is in part fueling greater interest. So in patients involving themselves in their care, so you need to meet their needs and meet them where they are. I talked about the portals everyone has that people don't use very much. Most studies suggest that only 10 to 20% of patients actually use their portals and actually remember their passwords and things like that. We have them. We met the regulatory requirements. When portals first became widespread, the way that a lot of hospitals and practices got patients to use portals was before they physically left. Someone would sit with them, sign them up, log them in. Well, there you go. Met the regulatory requirement, but was it really useful? As we think about the patient engagement tools you want, how do you meet the patient where they are? Push information to them with what they have, their phone, email, but mostly it's texting or an equivalent thereof, and then provide the access, enable them to access other information, obviously with the appropriate security. As we move to operationalizing the process, first step here is governance. What is the group that's going to monitor those targets that you already set? Who defined them? But what are you going to do if you have different targets from multiple programs? Not an uncommon situation where payer A sets one set of targets, perhaps both percentage-wise and actual clinical targets, and payer B sets a different one. No clinician wants to walk into a room or walk in front of a patient and think, oh, this patient has Cigna, therefore I'm going to do X. and this other patient has Aetna, therefore I'm going to do Y. We have enough of that with formularies and pharmacy decisions, some of which are reasonable. But in terms of general care, we're going to do the same thing. So how do we create that and create sort of that, for lack of a better term, a least common denominator here, so we can push that information to the clinicians to make them aware. Going back to my earlier example, that patient who came in, young patient with an upper respiratory infection, if that's where I'm focused, I might miss that they need their tetanus shot. But does it need to be me, or can it be the entire care team to help bring that together? And because of that, what you need for reporting from your solutions may differ from the clinical needs you need. So you need to consider both. So as you're looking at how you're going to report, what you're going to show people, what are the goals, what's the audience? And then how are you defining those interventions? Potential clinical, programs include, whether it's a palliative care item, disease management, again, diabetes, CHF, hypertension, quite common. Post-acute programs, are you going to do something special for people with minor acute problems? And then equally, what are you going to do about solutions for people who are well? Because they're part of your patient population as well. To bring them in, make sure they're getting the care that they need, do the prevention items that we know both improve outcomes and reduce costs. Part of this operational process is the education. Once you've identified the goals, how do you communicate that to the team? Frankly, knowledge is really empowering. Ensure that people know how their actions contribute to the whole will help drive them to do the right thing. I know I keep coming back to it, but going back, in the early days of meaningful use, I would spend a lot of time with members of medical staffs at hospitals around the country, and one of the questions I would always ask was, why is this hospital installing an EHR, especially when I was hearing complaints from the clinicians about doing it, using it, et cetera. I'm sure many of you have heard those kind of comments. And when the answer was, we're doing it for government or regulatory or some other variant of that answer, that was generally a very bad prognostic indicator as to how the project was going or was likely to go. We have to have workflows that support outcomes for the targeted populations. People need to understand who those populations are, how we take it forward, and how we take advantage and utilize the entire care team and empower members to change. Do we need to change the workflow? The answer is maybe. So we have to look to ensure that the workflow makes sense and that it supports patients being seen and patients not being seen, and which gets us to that ongoing monitoring adjustment. We're going to learn over time. This is not once and done, and I dare say no one is going to get this process right straight out of the box. We're going to keep making changes as we continue to learn new things. So what are the keys to success, as we look at this across the board? So first, you want to make sure you take a holistic view of care. All of the interactions with the patient, and breaking those care delivery silos. What can we do? If there's something that can be done when the patient shows up, can we take care of it now? Can we get them to the right place? Continuing to address current performance to identify areas for improvement as we continue to balance cost and quality. Those education programs I mentioned and getting the team on board. It's important to take advantage of every single interaction you may have with the patient. That means thinking beyond the inpatient visit. Telemedicine and other methods of patient interaction without the patient physically in front of you can be quite valuable. And the good news is that the reimbursement structures are changing, and frankly changing rapidly, that enables that more efficient use of both patient and clinician time. Events such as routine follow-up appointments for certain conditions were traditionally done in the office, as that was the only way to enable payment. But that's no longer true. And even conditions like a wound check might be accomplished via video. Now, I'm not suggesting that everything can be done remotely, not even close, but where you can, it may make sense. Taking advantage of the Internet of Things, connected scales, connected glucometers, and other devices that bring information back to the healthcare team. And part of the thing you need from those tools is to weed through that information. Getting a weight on every patient every day, or even every patient with congestive heart failure every day, would be overwhelming without the use of the system to help filter that down, to start looking at absolute changes, percentage changes, and pushing information in front of them people to say, all right, here are the people that need a personal phone call or some other follow-up. And with that, we can help prevent readmissions and other actions. And then finally, as discussed, a robust analytic strategy to help measure and report. What are you measuring? You want to ensure the information gets to the right people, which will help turn that data into information, which creates insights and enables action. And with that, I wanted to make sure we left plenty of time for questions today, so I'd like to turn the presentation back to Brian for the Q&A.
Thank you so much, Dr. Blackman, for that insightful presentation. And we will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we've had quite a few great questions come in, and I think we'll get started with this one. So Dr. Blackman, this attendee asked, why don't quality measures always align with medical best practice?
Well, the reason for that is several-fold. Not the least of which, sorry, lost train of thought for a second, is that as I mentioned, patients vary. And so thinking about, say, diabetes, where, the goal for diabetes, from the American Diabetes Association is to get to a hemoglobin A1C of less than 7. But from a pay-for-performance standpoint, if a payer set the goal of, well, we want you to have, 80%, 90% of your patients with a hemoglobin A with less than 7, what might end up happening, and frankly likely would, is there'd be lots of requests from people to say, well, wait a minute, my population's a little bit different. It's not really appropriate to have such tight control on all of these patients. So often the pay-for-performance goals, so those reporting measures, will be set higher. They'll still be set directionally correct. We want to move from where we are, but we're not going to get there in one shot. And it equally makes it easier to say, yes, we're going to include all of your diabetics. Our goal isn't tight control for everyone, but a reasonable, place to go.
That makes sense. And the next question I have here is, would you say perioperative medicine can be one to follow to achieve all this?
Absolutely. I mean, like other places in medicine, as you look at perioperative care, how are you treating that population? How do you, again, so when I talked before about you could define a population as, geographically based, disease-based, et cetera, you could define it as perioperatively based, and even get it down to service lines. To start looking at, what is the variance in care between patients within that particular service line? How do you take it forward? And how do you do those follow-ups? Especially in the surgical area, we see plenty of bundled payment arrangements. So the more efficiently one can do that with high quality, the better off we're all going to be.
Thank you. And we've got a bunch of great questions here. The next one we'll take is, are there any studies that prove population health is achieving the goals that you're discussing here? I
can't quote any published studies off the top of my head, We're still in the process of sort of experimenting in a number of different ways and looking at those costs and those outcomes. My hope is that we'll start seeing some of that data, but certainly the preliminary information that's out is that we do know that a variety of preventive options really do decrease morbidity later in life. So it is a reasonable statement to say the more we can appropriately make sure the preventative measures are attended to, and it's basic blocking and tackling, the more likely we are to improve outcomes. Now, I should note, however, that people sometimes talk about decreasing cost in that same sentence, and that's not totally fair. The fact of the matter is that if for an appropriate population, if 50% of those patients were getting mammograms on a regular basis, and you were able to move that needle and got to 80% of those patients having mammograms, well, you've just spent more money. Is that money well spent in the long run? The answer is probably. But it's a long-term payback. And just additionally,
yeah.
I just want to make one more comment on this. I spent some time working on this outside of the United States, in countries that have different payment models, and often with different kinds of payment models, people take a longer term view than we sometimes do here.
Gotcha. Some important distinctions there. And so this attendee asks, who are the most impressive patient engagement vendors you see out there who are able to change patient behavior at low cost?
As opposed to naming specific vendors, as I noted before, I'm the medical director for population health at Allscripts. So we certainly have some solutions in that area. But I think what you want to look for as you're looking at those kind of things is how efficiently can you reach out to patients? How easy is it for patients to then use it? What does the patient have to remember? And are you pushing a message to them? Do they then need to remember their passwords? Can they log in with something they're likely to know or remember all the time? What are those ways? Obviously, the security is really important here. But how do we make it easy for people to take advantage? Those are the features I would look for rather than naming specific vendors. And I would certainly, I would say that our Follow My Health solution really does that pretty well.
Great. And so this next question here, the attendee asks, could you provide any suggestions or insight into using these strategies to implement a more effective MedRec process within the PCP offices?
I missed I heard the beginning of the question, which was MedRec. What was the end of it?
The end of it was, I'll just go ahead and read it again. So, could you provide any suggestions or insight into using these strategies to implement a more effective MedRec process within the PCP offices?
Sure. Yeah. So medication reconciliation is difficult on a good day. I freely admit that when medication reconciliation first became a Joint Commission requirement, as a somewhat, anal retentive internist, I was like, okay, what's the big deal? This is sort of what I do already. But the fact of the matter is that it's about communication. So as I think about how the population health process can help, it can help by providing that access to that more global med list to get a sense of what the patient's on. One of the big complaints we hear from patients commonly is, quote unquote, you people don't talk to each other. And that's because they get asked the same question over and over again. And now there are plenty of good reasons for asking the same questions multiple times. But using these tools, there are ways we can do that better. So thinking back to MedRec, as opposed to starting the patient, what medications are you taking? Saying, I see that you're taking A, B, C, and D. Did I miss anything? Well, at which point in time the patient may say, oh, yes, and they remember E that they didn't mention before, as opposed to just reciting what they said previously. So the more that we can share that information, the better off we're going to be. Now, there are other sources from multiple EHRs, sources, potentially from pharmacies. And again, this is the list of medications that have been prescribed. Perhaps it's the list of medications that have been dispensed, but it isn't necessarily the list of medications the patient is taking. So, MedRec is still going to be a lot of work, no matter what we do going forward, but it's critically important work. But I do think there are tools here that can help us with that, keep that global list and help us keep it up to date.
Great, and some really, really great, helpful patient engagement strategy there, just for face-to-face interactions even. So this next question here, please discuss some of the clinician workflow challenges between data actions found in the EHR versus a PHM solution.
So it was data found in the EHR versus what? I'm sorry?
Sorry about that. So the attendee asks if you could discuss some of the clinician workflow challenges between data and actions found in the EHR versus a PHM solution.
Okay. So I think at the end of the day, you have to be able to combine them to put together, that, which comes back to that workflow question. Where is the information presented? If you want to take the action, based on your population health management solution, based on that global data that's available, which includes the data in the EHR somebody's working in, and as we go forward, you want to enable it within that clinician's workflow. If I need to go to a different place, if I need to log out of my EHR or simply leave it open and log into a different system to see that more global view, you're not likely to do it very much, truthfully. So those workflows need to come together, and ideally, and we're still, this is like everything else, it's a work in process to enable those actions so that the population health management solution suggests that this patient is overdue for their tetanus shot. Let's work together to make it actionable from there. The more those alerts become actionable, as opposed to, oh, I have this piece of information, now I have to navigate to the appropriate place in the EHR to place the order. Again, time, efficiency, and working them together. But there's no question that the EHR is key in the workflow, but we need to combine the two.
Great. And the next question I have here sort of builds on this idea, this challenge of disparate data. It's a longer one, so I'll take it a little slow. But the EHR often does not capture all data needed to perform pop health and value-based care, i.e. needs claims data from other providers a patient has seen outside of that provider's network. So what systems have access to sufficient disparate data sources to accomplish this?
So that becomes a question of how you sort of define your network. We certainly have the ability to bring, when I say we, I mean Allscripts has the ability to bring in data from multiple data sources and normalize that data, while keeping the original provenance to present it in a way that makes sense to clinicians and can be reviewed together. We're going to continue to see increasing, data shares from Care Quality and Commonwealth, currently being shared through CCDA documents, being able to parse those documents to pull the information together. So I think the key becomes that step in normalizing that information and putting it in the workflow in a way that makes sense. If it's simply a collection of CCDA documents that one has to go look at, there's a lot, frankly, first of all, there's going to be a lot of duplication, and secondly, it's essentially a stack of electronic paper in that form by itself. And the chance of finding what you're looking for and really using that information to drive decisions is much harder. So we have to be able to parse the information and then put it back in the workflow, either into the EHR itself, and there are reasons to do that. There are frankly probably more reasons not to. On a global basis, I'm not saying you wouldn't want to put some of the data back into the EHR, but within that same framework to be able to say, all right, this is what you don't have, and quick and easy access. I hope that answers the question.
Yeah, absolutely. Thank you for tackling that one. And so the next question I have here, this attendee asks, what's the role of patient-reported outcomes to assess improvements in quality of care?
I think patient-reported outcomes are really important because the fact of the matter is that it's how the patient is feeling that is important. How do we, just because, as the clinician, I think they should get to a certain point, we need to think about what's the patient's goal. And so if we have the patient's input, and if their goal is to play with their grandchildren, walk up a flight of stairs, be able to go walking with their spouse, whatever the case may be, if we're working with them on targets that make sense for them and where they want to go, then we're doing the right thing.
Yeah, it certainly sounds like patient-reported outcomes are an essential component of all of this. And our next question will be the last question. So I really appreciate you tackling all these, Dr. Blackman. And this attendee asks, any insights on ideas to address transportation issues? We have a number of patients who struggle with this and call an ambulance, which will take them to the ED, even when that is not always the right care setting for their issue.
Yeah, no, transportation is always a problem, especially in certain communities. Ambulance is not necessarily the best way. Once you call an ambulance, they will decide where to take you. So sometimes it's as simple as getting simple. Simple is the wrong word, but simply it's as straight. The goal is simply provide someone access to their provider. Allscripts, for example, does have a partnership with Lyft, where we work to get people rides to their doctor's visits. Those can be ordered out of the EHR and other pieces to help get people to the right place. Because we certainly don't want transportation to be the obstacle that prevents someone getting the appropriate care. I mentioned earlier that there's some care that can be done remotely, but that's certainly not always the case. And if someone doesn't come in when they need to for appropriate follow-up care, and transportation is the barrier, which, as I said, we're working to break down, what will end up happening is, at some later date, they will call an ambulance. They will end up in the ER, all of which could potentially be avoided. Thank you, Dr. Blackman. And before we sign off, do you have any final thoughts to share with our attendees today? Yeah, just one. And I would just say that a successful population health strategy requires thinking broadly and a team approach. There are numerous decisions that people have to make, but in general, and those decisions are affected by any number of factors. But in general, if you keep what is best for patients in focus, you're likely to make good choices. Perfect thoughts to end on there. Thank you again for your taking all those questions and that fantastic presentation, Dr. Blackman. And that is all the time we have for today. I'd also like to thank Allscripts for sponsoring today's webinar. Everyone, enjoy the rest of your day, and we look forward to having you join us for future webinars.